did a study on surgical site infection, so women who became infected after cesarean delivery. And we specifically looked at obese women. When you look at the rate of surgical site infection after C-section, obese women have a 2 to 5-fold increased risk in getting either infections in their wound or infections in their uterus after the delivery. So we targeted that population, and our hypothesis was that if we kept them on antibiotics, broad spectrum antibiotics, for 48 hours after delivery, that we would be able to reduce their rate of surgical site infection. We had a 60% reduction in the rate of surgical site infection when they were continued on broad spectrum antibiotics for 48 hours after delivery. If they had a broken bag of water at the time they underwent their cesarean delivery, we found a nearly 80% reduction. Actually, we had very few women who withdrew from study participation. We only had 12. 4 of those women withdrew prior to receiving their first dose. So at some point between when they were enrolled and when they would have received their first dose, they decided they didn't want to continue in the study anymore. 8 women out of 404 stopped taking the medication at some point after their first dose. And the most common reason was some nausea associated with the pills.
But so based on the tolerability and safety findings in this study, you're pretty comfortable that this could be used? Absolutely.
I purposefully chose a regimen that is common and widely tolerated and safe. The cephalosporins that we continued women on, all women receive at the time of their cesarean delivery. This is just an extension or a continuation of that exposure. And then metronidazole is also a very common medication used for a variety of purposes. And so I knew that those medications generally were well tolerated with low allergic risk and such.
So what do you see as the implications of your findings?
I am very excited that we found a way to help women like these. And then these women in the study were very high risk. They were obese. They had high rates of tobacco use, high rates of chronic hypertension, high rates of diabetes. In those women that are at the highest risk for surgical site infection, we found an effective way to reduce the risk of infectious complications after their delivery. And I think that that is very exciting. Historically, these women have had very high risk for these morbidities, and so it is very exciting to me that we found a way to help prevent that.
And you were telling me that you see a couple more steps, though, before even at your institution at the University of Cincinnati you start instituting this protocol. And what does that involve?
Well, there's been 2 major trials that have come out recently, mine and another study as well, that looked at ways to prevent surgical site infection. And I think our biggest challenge is going to be reconciling those 2 studies. They looked at 2 different populations of women, and kind of bringing what we've learned from both of the studies together to come up with a protocol that we can implement at our hospital. It's a little bit challenging, and we want to make sure we review all the data, not just my one study, but all the data that's out there, and kind of come up with the best evidence-based approach to antibiotic prophylaxis at C-section.
Yes, but do you think it sounds like going forward that in the near future, for high-risk women such as this, some kind of prophylaxis will be used routinely?
Absolutely. I think given the significant reduction we found in infectious complications, that we will very readily implement this in Cincinnati. And I believe other centers who take care of women with the same level of complexity that we do will also be using our study to help improve the way they prophylax for infection.